All right. Good morning, everybody. This is Jill Hansen at the Wisconsin Hospital Association. I want to thank you for joining us today for the Difficile Diagnostic and Clinical Challenges is 3 times the Charm webinar. I am proud to present that Barb DeBon is going to be our presenter today. She is an improvement advisor for Cynosure Health and provides individual and team coaching and facilitation to promote patient safety and quality improvement. She recently supported activities associated with the American Hospital Association Health Research and Educational Trust, CMS Partnership for Patients Hospital Engagement Network contract. So that was also part of the WHA HEN. Barb is also a certified infection control practitioner and earned a Bachelor of Science of Nursing degree from Pace University in New York City and a Master of Science degree in nursing from San Francisco State University. She currently serves as an elected member of the Board of Directors for the Association for Professionals in Infection Control and Epidemiology, which is APIC, and APIC recently appointed Barb as a member of the 2014 APIC Task Force on Ebola. So at this time, I'm going to turn it over to Barb.
Well, thank you, Jill, and thank you, and good morning to everybody on the line. It's really a delight to be here and have a discussion about one of my favorite topics, and I think a topic that's become increasingly worrisome and problematic for those of us that are working in healthcare. So Jill is going to be my co-captain here, and she is going to be advancing the slides. So Jill, if you could take us to the objective slide, and I'll run us through that. So my primary goal today, and I really hope to have a lot of conversation, a lot of input from everybody on the line, I'm going to just do a really brief overview of the tests that we currently have available to us to help us identify patients that have C. diff. There are clearly benefits and clearly weaknesses of the tests that we have available to us, and I hope to be able to point out their strengths and weaknesses today. I'm going to have a little bit of a discussion about the role that sensitivity, specificity, and predictive values of these tests have, because there's a lot of misconception about the importance of sensitivity versus the importance of predictive values. So we'll have a discussion about that. And then at the very conclusion, I'd like to have a discussion about how we really think about culturing, what we culture, why we culture, and what we do with the results, because there's been a tremendous amount of chatter, especially in the infection prevention world, on the role of the culture of culturing. So that'll be how we'll conclude the session today. Next slide, please. So this is just a little bit of overview background. I know Jill has shared with me that you've been doing a lot of work in the state of Wisconsin on C. diff, but just to make sure that we're all grounded with the same data, it's important to know that between 3 and 7% of just healthy adults are colonized with C. diff. We know that asymptomatic colonization, which means that people have the organism but they don't have any diarrhea or symptoms, it's more common in people that have actually been in a hospital, that have received health care. We know that up to 15% of people that come into the hospital are simply colonized with C. diff, and this is important because it plays a potential role in the transmission of C. diff in our centers. We know that if a patient comes from a long-term care facility, up to 50% of these people are colonized, and that's a huge burden of disease. And then we also know that somewhere between 7 and 21% of patients that are hospitalized at some point in their hospitalization become colonized. And then somewhere between 4 and 15% are asymptomatically colonized at the time of admission. All of these statistics are important because we've been reading and hearing more and more about the role of the unidentified patient and potentially the role of the people that were potentially over-diagnosing. So if we could move to the next slide, we have a lot of challenges, and one of them is related to the fact that diarrhea is a really frequent thing in people that are in hospitals, and there are a lot of other reasons and causes for diarrhea other than C. diff. So if we look at this statistic, we know that C. diff infection affects less than 1% of patients that are in the hospital. So that doesn't make it sound like such a big deal, although we know it certainly is. But it's the cause of diarrhea in only 5 to 10% of hospitalized patients who have diarrhea and are tested for C. diff. So this makes our work even more challenging. Next slide, please, Jill. And just a little bit of background, because it's important for us to remember, not all of us are at high risk for colonization of C. diff. We certainly know that infants are, which is why we have to be really careful about not testing infants, because we know that they are colonized for at least the first year of life. People with inflammatory bowel disease, I already mentioned anybody that's been in a long-term care facility, a SNF or rehab, particularly patients that have been recently in the hospital. A real key risk is antibiotic exposure, specifically in the last couple of months. So any patient that's admitted to the hospital who can say that they've been on an antibiotic, and it doesn't have to be a long term, it could have been a couple of doses of antibiotics, is a really high risk for colonization. If someone's had it before, if they have a prior history of CDI, then they're more likely to have it again. Patients that are obese are at higher risk for colonization. And we know that patients that are taking a proton pump inhibitor, and a lot of patients take these pills for peptic ulcers or GERD, because what they do is they actually reduce the amount of acid in the person's stomach. These have been associated with a higher risk for colonization. But basically, anything that messes up our colon, anything that gets into the colon and messes with our normal natural flora can put us at higher risk for colonization of C. diff. Next slide, please. So when we think about C. diff, one of the key components to it is we got to find it. If we don't recognize it early, not only can we not treat it, we can't claim it as community acquired or community onset. And the more important thing is we can't do the kinds of things we have to do to prevent the transmission of C. diff, especially in our facilities. So early recognition and screening is a key component to anybody's C. diff reduction program. So the next slide has two different ways of screening, and I know many of us have learned about this incredibly talented beagle named Cliff. And seriously, apparently this beagle has got the ability to sniff out C. diff. But, he's not all that special, because when you think about it, if you ask a nurse, most nurses will be able to tell you, oh, yeah, it's C. diff. I know. I can smell it. And so nurses have an acute ability to actually smell the difference when somebody has C. diff. But unfortunately, we can't count strictly on animals or nurses to test. So we have to really depend on the laboratory test for C. diff. So the next slide is just kind of a brief overview of the most common tests that are available for screening patients with C. diff infection. And I'm going to go through these one by one and point out the strengths and weaknesses of each test. What's important to remember is that back in 2014, NHSN required every hospital to let them know which kind of test they're using. And it's really important that we take a mind that we're mindful of this, because the type of test that we're using has a significant impact on our rates. And we're going to get into that a little bit more as we get through the discussion. So let's go on to the next slide. In general, there are two different kinds of tests to test for C. diff. There's tests that actually look for free toxins, and then there's tests that look for toxigenic strains of C. difficile. So that's important to remember, that there's really different things, different kinds of tests to look for. What we have to remember is that the culture, although it's still considered kind of the gold standard, the problem is that it's really primarily used for research, because it just takes too long to get the results. It can take days to get the turnaround. It takes a lot of labor to do, and it's really just not something that's clinically appropriate for us to use in healthcare. So although cultures are super, super accurate, they're not practical in our healthcare setting. So what I'd like to do, starting with the next slide, is to just speak about each of the tests that are commonly used in our healthcare settings, and again, talk us through some of the risks, some of the positive things and the potential negative things. So the next slide is an overview of EIAs. So I believe, and I would love to hear as we have discussion later in this presentation, is what tests you're commonly using. But from the literature and the conversations that I have with my colleagues, the Toxin enzyme immunoassays, or the EIAs, and the NATs are the most commonly used tests. So let's think about EIAs first. They became available in the mid-'80s, and they were quickly adopted. The problem is that we quickly learned that their sensitivity wasn't that great. And as a reminder, sensitivity is really a statistical measure to show the proportion of positives that are truly, truly positive. So if a test is highly sensitive, you have a much greater chance, if it's positive, to say, well, the patient really has this condition. The problem is because the EIAs are not all that sensitive, what it resulted in was clinicians were saying, well, patient has diarrhea, we tested it, patient's negative, you know what, let's do it again. Let's test them a second time. And then, you know what, that's negative. But, I really think this patient has C. diff. So let's test them again. So it kind of created this culture of EIA times 3. And the problem with that is it caused a lot of problems because we were putting too much reliance on a test that was not giving us accurate results. So many hospitals, not most, but many hospitals have stopped doing just the standalone EIAs because of this concerns about the sensitivity and the concerns that we're going to get false negative results, because the more you test, the more likely you are to have a negative test. So it is currently strongly recommended that EIAs are not performed for just initial diagnosis. Doesn't mean they're not recommended to use, but for the simple standalone diagnosis, currently not recommended. If we go on to the next slide, this is just a little bit more about EIAs. This is a really important piece of information. The negative predictive value of toxin EIAs is at least 95%. This means that the likelihood that the test will generate a true negative. So the confidence should be pretty high that if we do one test and it's negative, that the patient probably is negative. So therefore, we do not automatically want to repeat if the first or subsequent tests are negative, because every time we do another round, it increases the risk that we're going to have a false positive test. And that's the problem. We keep testing and testing and testing until we get the result that we think we want, and then we have a result that's positive, but it's very likely a false positive. And that's really important, especially in low prevalence populations. And we'll get to that a little bit later, that it's really important that when we are testing people, that we have a sense of how likely this person is to have this particular disease, because that's greatly going to influence or really affect the accuracy of the test that we're using. So let's move on to another test, which is the glutamate dehydrogenase enzyme immunoassay, or GDH. This can detect the organism, but the problem with GDH is it can't tell the difference between toxin positive from toxin negative. So you can find the organism, you can say, okay, the patient has C. difficile, but you don't know if they've got toxins or not, and that's really significant. So this cannot be used as a standalone test to confirm that there's a presence of toxigenic strains. And the sensitivity ranges are between 75 and 90%. So that's kind of the story with GDH. Moving on to the next slide, and NATs, or nucleic acid amplification tests, PCRs, or polymerase chain reaction, PCRs are the most commonly today used diagnostic tests to detect C. diff in the hospitals in our country. They're easy to do, they're fast, they're highly sensitive, and it's very unusual to get a false negative result. So you're sitting there thinking, well, then that's great. You should just, use PCRs because they're quick, they're easy, they're fast, and chances are that if we get a positive test, that it's a true positive. But there's problems with this, and we'll get into this in a little bit more. If we look to the next slide, what is becoming increasingly popular and recommended by not just clinicians, but most of the literature, is that a two-step approach is really going to be necessary to confirm that the patient not only has C. diff in their colon, but they have active disease. Again, what we're trying to figure out is the patient just colonized with C. diff, or do they have C. diff and toxin, which means that they have C. diff disease? And we've got to figure out how to differentiate this, because we do not want to be treating patients that are simply colonized. So the two-step approach would be to do a PCR or a GDH first and then test for toxin. And this is becoming increasingly popular in the literature and in the discussions that I'm hearing with clinicians that are studying this real big problem that we have. So moving on, Jill, to the next slide. There are some studies that look at the different CD tests and to try to figure out, well, which ones are better. And here's the primary problem. The studies don't have any data on the patients. So we really don't understand what kind of patients were these tests used on. Were they used on patients that were highly likely to have C. diff, or patients that had diarrhea and were highly likely to have diarrhea because of something else? So again, without clinical data, we really can't differentiate between asymptomatic C. diff colonization and Clostridium difficile infection. So that is the problem with the studies. So we have additional problems, and if we move on to the next slide, there are really like three huge issues that we're struggling with today. The first one is the concern that the toxin assays that we have are just not sensitive enough. Here's what we know. The sensitivity of a culture to try and pick up C. diff in somebody's stool is way higher than the sensitivities of the assays that we have to detect toxins, especially if the patient is asymptomatic. So it's a lot easier to find the bug than it is to find the toxin. So that's a challenge. We do know that the amount of toxin in a person who's asymptomatic is lower, so that's a good thing. But without clinical data, and this is really the key issue here, without knowing anything about the patient, what we thought was if the patient's culture was positive, but their toxin was negative, the interpretation was that these patients had CDI, but their toxin was negative. But now we understand, doing some more clinical studies, when we have clinical data on the patient, what we've learned is the great number of patients that are culture positive but toxin negative are people that don't have disease. They're just asymptomatic colonization. So the real pivotal piece here is that understanding the limitations of the test, understanding that a positive culture but a negative toxin, rather than blaming the test and saying, oh, it's a false negative, what we're really learning is that when we dig into the data and understand what patients we're testing, if we get a positive culture and a negative toxin, these people probably don't have disease. So this is really, really critically important to understand. The next slide, please. And this I've already mentioned, but what continues to really happen, and a lot of this is about how our clinicians were trained and how they teach the new regime and the new interns and residents, is that we have habits. And, as we know in healthcare and just in life in general, habits are hard to break. And when we have habits of saying, well, this test is not that sensitive, so, we're going to just keep doing it until we get the result we expect to get, this habit of doing the C. diff times 3 is a major problem, because we test and we test and we test, and then eventually you get a positive test, and it's probably a false positive. So that's a major, major issue. And then on the next slide, the third issue is that if we don't really recognize how important it is to think about negative and predictive values, then we're really, really missing the boat. And I'm going to get into that in a little bit. But what's important to remember is every time if we do a test and it's negative and we repeat it, what we're doing is we're reducing the prevalence of the disease we're testing for, and in this case, CDI. We're reducing the prevalence of CDI in the population. So what that means is that if you have less CDI in your population, your positive predictive value also decreases. So by the time you get to the third test, there's less than a 20% chance that if you get a positive test, that's a real test, that it's a true positive. So again, the more we test and the more we test and we keep getting negative results, the prevalence is reduced. We have less predictive value. It's much more important to focus on the predictive value of the test rather than the sensitivity. So I'm going to walk us through a couple of exercises that I think will help this kind of make a little bit more sense if it's not already making sense. So if you just look at this screen, this C. diff detection screen, if we look at the current tests, and this is again PCR and GDH, common tests that we use today. If you look at them, the PCR highly sensitive, and that's again why I think a lot of us use it, because we know that we have a greater chance of if it's positive, it's a true positive, and if it's a negative, it's a true negative. But if we look at the positive predictive value, there's some question marks here, and I'm going to show you what I mean by that. So if we look at the next slide, what is pretest probability? What does that mean? It really is how likely is it that this patient that we're testing has the condition or the disease that this test is designed to find. So how likely is it this patient that we're looking at right now, how likely, what's the probability that this patient has C. diff that this test is designed to find? So I'm going to use a couple of examples. So if we move on to the next slide, and I'd like to credit my colleague, Steve Tremaine. I know many of you know Dr. Tremaine. He did this really nice overview in the HRET C. diff. Actually, it's the most recent change package, and he did this exercise in there. So I've totally stolen this from him. So thank you, Steve. But I think it demonstrates a really key point, and I learned a lot from going through this. So here's an example. Here's patient number one. You've got a 50-year-old man who's admitted from home. He hasn't been in the hospital or a long-term care facility. He has three loose stools on day 4, and you're thinking, oh gosh, why couldn't it have been day 3? Day 4, the dreaded day 4, he has 3 loose stools. We do a history of him. We find out this patient hasn't had any antibiotics. And it says the last 14 days, so he hasn't had any antibiotics. So the pretest probability of C. diff in this population, in this person who hasn't been in the hospital, who hasn't had antibiotics, who doesn't have any of these higher risk kinds of conditions, the average pretest probability of C. diff, say, is about 10%. So let's learn more about how we would interpret the results on this patient. So the next slide, what this would mean is 68% of the results would be true positive. Now, that would mean, which is the scary piece, is the false positive rate in this population would be 32%. That is huge. That means that if we have a patient like patient number 1 with no risk factors for C. diff, and we test them with a highly sensitive test, that we're going to find a lot of people that are going to test positive, but it's going to be false. So that's huge. And I'm going to take it to the next slide. Oh, sorry, that was a little, okay, thank you. So here's the math. And this is for those of us, and, you know, I will, this is true confession, and this is, I tell my friends this all the time. My mother was a math teacher, and she was brilliant, obviously, at math. And she had to bang it into me. I did not inherit the math gene. So this is why we put this out here for people like me that need the math. So here's patient 1, and this is just kind of to put you through it. So we use a PCR, sensitivity 95%, meaning that 95% chance that it's going to be a true positive, specificity 95%. So this really means that it's a really, really, really good test, highly likely to be accurate. But with this patient, this 50-year-old patient, the pretest probability of C. diff is only 10%. So if we have 1,000 patients like patient 1, 100 patients would have C. diff, 900 would not have it. So the key message here is if we have a highly sensitive test, 95%, we're going to identify 95 of the 100 patients with C. diff who really have it, and we're going to miss 5%, we're going to miss 5 of the 100 with CDI, so we're going to have 5 false negatives. The real significant problem here is with a test this specific and sensitive, we're going to end up with 45 false positives if we use this PCR test in a population with a really low probability of having this disease. This, to me, is really critical to the discussion of how we test our patients and why it's so important that we have clinical information about our patients and only test when it's clinically appropriate. So let's compare patient 1 to patient 2. So the next slide, a completely different scenario. We've got an 80-year-old patient who was transferred to your acute care facility from the skilled nursing facility, had 3 loose stools since admission, has been on antibiotics for a presumed urinary tract infection. Now, in this patient, compared to patient 1, where there was a 10% pretest probability, in this patient, there's a 50% pretest probability. And we can see that patient was in a SNF, patient has been on antibiotics, and likely a lot of antibiotics in his last at least 10 years of life. So let's look at the comparison on the next slide. 95% would be true positive. The false positive rate would be 5%. 95% would be true negative. The false test rate would be 5%. So a very, very different scenario than patient number 1. And I'll take you to the next slide. And again, here is the math for this patient. Again, we're using a highly sensitive and a highly specific test, PCR, pretest probability 50%, very different from the 10% of the 50-year-old patient. So for 1,000 patients, just like patient number 2, 500 patients would have CDI, 5 patients would not have CDI. We would have 25 false negatives and 25 false positives. So it's really critical, again, to remember that if we're using just PCR, and really regardless of the patient population, we are going to have a situation where we're going to definitely have false positive patients. So even with patients, even when we use a highly sensitive and specific test in patients who have a low pretest probability, like our patient number 1, in a patient, we're going to have a high percentage of positive tests that are false. And that is really critical to how we treat these patients. We're going to have a lot of patients with false positives. So the next slide asks a really important question. Are we over-diagnosing CDI? So again, reminder of some of the statistics and some of the data. 90% of hospital onset diarrhea, 90% is not due to CDI. It's due to other things. Tube feeding, laxatives, enemas, a lot of different medications, other kinds of infections, underlying diseases. I mean, we can even add things like stress, just anxiety of being in the hospital. There are so many things that can cause diarrhea. The next slide, and this takes us back to really how using strictly PCR can impact us. Reminder, we know that many patients are admitted as carriers. They're just asymptomatic carriers. We also know that patients can become carriers after admission. And as a reminder, the PCR, what it does is that it identifies the toxin-producing organism, but it cannot tell the difference between C. diff disease from C. diff colonization if it does not identify the presence of the toxin. So I think this is a really, really critical point to overemphasize, is that PCR identifies the organism but not the presence of the toxin, and it can't tell the difference. So without clinical information and studying the patient, we really don't know if it's colonization or active infection. So the next slide. So where does this leave us? So here's what we know. Toxin immunoassay, so EIA, by itself, we know it's not sensitive enough. We know that there's a lot of false negatives. We know that it's leading to underdiagnosis. We know that. So we have PCR, which we know is highly sensitive, highly specific, but the problem is the PCR's predictive value is really based on how likely a particular patient could have CDI. So if we think about patient number 1 versus patient number 2, it really depends significantly on how likely a patient could have CDI. So the next slide really leads us to a very, very important paper that I would encourage, and I can certainly share this with you, Jill, and this is something else we can make available to everybody on the call today. But I would strongly encourage carefully reviewing this paper. because this paper has really identified, I think, a very, very significant problem in that we've got a supremely fabulous test, PCR, highly sensitive, highly specific, really good test. But what we're learning is that we have got a lot of limitations because if we don't really know anything about the patient and we're using this test on patients that are not likely to have C. diff infection, that we are over-diagnosing C. diff infection. So what does that lead us to? Let's go to the next slide and discuss a little bit some of the implications of over-diagnosis. So I would like to know, I'm presuming that most of us use either contact precautions or even enhanced contact precautions for patients with C. diff. So what does this mean? We need a lot more single rooms. We need a lot more personal protective equipment, such as gowns. Studies have absolutely shown that patients do not like to be on contact precautions, especially enhanced contact precautions. They're anxious, they're depressed. Studies have shown that there's higher negative outcomes as a result of patients being on contact precautions. They get a lot less visitors, a lot less interactions with healthcare workers. And then another real important implication of overdiagnosis is just the impact of our data and whether or not we are claiming to have a lot more C. diff infections than we really do, and how does this really impact the potential value-based purchasing decisions. So these are really critical implications of overdiagnosis. The next slide, in my opinion, is the bigger problem. The biggest implication of overdiagnosing is we're treating patients who don't need to be treated. We have got patients who are being treated for CDI who really are only colonized. And what does this mean? Well, how do we treat CDI? Well, as you know, ironically, we treat CDI that's caused by antibiotics with more antibiotics. So we increase their risk for any kind of drug-related adverse events. We also know that the more antibiotics, the more likely the patient is to develop even more multi-drug resistant organisms. And we also know that once we stop the treatment, the patient has a higher risk of having real CDI. So this, in my opinion, is the real problem with implications of overdiagnosing. So what I think we really need to shift our conversation to now are we need to think about what are the real strategies to increasing our pretest probability of a positive test. That's really what we want to do. Our ultimate goal is to minimize clinically inappropriate testing. We don't want to overtest, we don't want to overdiagnose, and we certainly do not want to treat people that are asymptomatic or even potentially marginally symptomatic. So what I'd like to do now is to move on to some specifics around cultures. A friend of mine sent me this card, and I just thought it cracked me up, so I wanted to share it with you. And it says it was Nurse Haggard's job to collect all the stool samples. And I know the nurses out there will get a chuckle at this, that she was collecting the stool samples. I wish it were that easy, don't we all? So the next slide, for most of us that have been in clinical settings for most of our careers, we're familiar with the Bristol stool chart. And you can see the chart is really a way to differentiate the different kinds of stool, and only nurses can get really, excited about a Bristol stool chart. And if you look at the chart, if you look at the chart, if you look at the very bottom of it, type 7 is really the only type of stool that clinically would meet the definition of an appropriate sample to send for C. diff. And then I also pulled this lovely cake on the right-hand side of the slide from a nursing website, and this is the Bristol stool chart. And again, only nurses could make a chocolate cake with the different kinds of Bristol stool, and then obviously enjoy the cake and eat it probably with tongue depressors, as we're so good at doing. So this is a way of really reinforcing the fact that the specimen matters in a very big way. So if we move on to the next slide, our number one strategy really has to be to limit testing to unformed or diarrheal stool specimens. got to be our strategy. So Stephen Brecher, and for those of you that have had the pleasure of hearing him give presentations, he's extremely practical, and these are his actual guidelines, and I've just taken them right from his paper. First is you got to look at it. You got to look at the stool specimen. And his saying, which I love, is that it ain't loose, it's of no use. So a specimen that is literally solid or has chunks is of no use when you're testing for C. diff. The other thing is you take a stick and you put it in the specimen. If the stick flips over and hits the side of the container, meaning if the stick falls, you can test them all. If the stick stands up, it means it's still too solid and technically is not conforming to the shape of the container. So really, really important strategy to list testing to diarrhea stools. The next slide. Specimen collection, and obviously this container that has a stool sample should be rejected from the lab for many reasons, but clearly it is not a diarrheal stool that is conforming to the shape of the specimen container. So specimen collection, it should be in a clean, dry plastic jar, and the screw top should be for obvious reasons, because if you've got a diarrheal stool, you certainly want a screw top to keep it all in there. We really want to get it to the lab right away. What we know is that toxins break down if they're kept at room temperature. So if there is a slight delay in getting it to the lab, we need to refrigerate the specimen, but what's really important is to get the specimen, get it fresh, and get it to the lab as quickly as possible. Next slide. Another important tool, and this is a diarrhea decision tree that I obtained from University of California, San Francisco. And there are a lot of different hospitals that have put together decision trees. I have a colleague who put together one, and she prefers to call it a diarrhea flow chart, which I think is pretty funny. But there are a variety of different tools that have been developed. And what's really nice about these tools is they really cause us to do some critical thinking. They really force the question. And if we go to the next slide, Jill, I think it'll be a little easier to see. On this particular flow chart, the question is, has the patient received a laxative in the previous 48 hours? Now, I've seen other flow charts, and Jill, I don't know if it's appropriate or if it's convenient to pull up that flow chart that Mark Oliver Wright shared from UW. If we can, that would be great. And if not, I can just speak to it. Oh, looks like it's on its way. Awesome. Okay. So I know most of you know Mark Oliver Wright, who graciously shared this really, really nice flow chart that he has made available, and he would encourage all of you to certainly use it. But please give UW credit for developing this, because I believe they hope to be able to publish this as part of a paper. But when you get a hard copy of this, you'll be able to see it a little better. What I really like about this flow chart is it causes us, it prompts us, it reminds us to ask the question, could the diarrhea be due to something else? A new medication, anything associated with a stool softener, laxative, enema, a bowel prep, lactulose, tube feedings, IV contrast. What I really, really like about this is, again, it forces us to do a real thoughtful assessment of the patient. And again, what does this take us back to? It takes us back to predicting. We want to test patients that have a high probability of having C. diff, and potentially not testing somebody that really has a lot of other explanations for diarrhea. So I think this is a brilliant, brilliant tool, and I would encourage you to take a look at it, see how you might adapt it in your settings. And again, if you see or have a chance to have contact with Mark Oliver Wright, to thank him for sharing this. He's also got a beautiful one for pediatrics, which you'll be able to share also. So yeah, there's this little pediatric one with a little dude up at the top. So these are both going to be available to you, and I would encourage you to use them and adapt them to your settings so that you'll be able to more critically think about what kinds of patients are being tested and why. Okay, so if we could go back to the slide presentation. All right, perfect. The next slide. Oh, one more. Okay, here we go. So we spoke about the real important responsibilities of the people that are gathering the specimen. The lab also has a huge responsibility. So these are some more strategies. And again, the strategies are really to increase the pre-test probability that the patient has the condition that we're testing for. So test the right patient on the right sample, use the right test for combinations, making sure that we only test diarrheal stools. If we're using a really sensitive test, we don't have to repeat. It's extremely important that we do not test for cure. That's a hard habit to break because for so many years it was banged into us that we had to keep testing our patients who had things like MRSA to get a negative culture. So testing for cure is absolutely strongly advised not to do. Use an algorithm with a test that has good sensitivity first and then a test that can also detect the toxin. Again, the test that just picks up the organism does not diagnose C. diff infection. It only tells us the patient has the organism and not the toxin. And then make it hard to do the wrong thing. How do we create barriers? We have the lab empowered to just say to reject the specimen. They certainly do it with sputum. If a sputum is sent and there's too many epithelial cells, it's rejected. So they should do the same thing with stools that are being tested for C. diff, and they should not allow automatic repeat testing or test with cures. Many of the algorithms that I've seen have limitations that you cannot test within 7 weeks, but it really, 7 days, but it really depends upon the facility and the discussion and the decision that you make. But this is really important for the lab to do in order to, again, increase the pretest probability. The next slide is just some more things. This is really just reinforcing don't test formed stools, make sure that we limit repeat testing, be very, very careful about testing infants. And then, again, the lab asking, well, has the patient been screened? And I think the more conversation the lab has with the clinicians, the more the conversation will continue to be a healthy one and reinforce the fact that if we're just testing and not doing a clinical assessment of the patient, that we are most likely over-diagnosing. And the next slide. So for more clinicians' responsibilities, it's extremely important that the clinicians understand the limitations and the strengths and weaknesses, really, of the tests that each hospital is doing. And tests are all across the board. And as we know, a lot of our clinicians go from one hospital to the next, and they have to really understand that the test can be very, very different. And the impact that lab results have on patient treatment is enormous. So the clinicians have to be up to speed on this. The next slide, there are certainly CDI studies that included clinical data. We know that between 35 and 50% of patients who tested positive for C. diff do not have clinically significant diarrhea. So that is really, really critical to remember that. So these are patients that are probably or very possibly just asymptomatic carriers. We also know that people that were tested, up to 40% of the patients that were tested for C. diff had recently received a laxative. So again, they were not using a really good algorithm to critically think about whether or not this patient should truly be tested. So we desperately need more studies to compare the testing of C. diff that can compare the different assays and also include the patient's symptoms and the patient's outcomes. Next slide, please. So a real important question, and it's one that's been floating out there for quite some time, is, why don't we just screen everybody? Shouldn't we just screen? We screen people for MRSA. Why don't we screen them for C. diff? We do know for a fact that asymptomatic carriers do contribute to the spread of C. diff in the hospital. So we know that. So that would be the argument for screening. But the problem is we don't really know how much C. diff infection in the hospital comes from people that are asymptomatic versus symptomatic, or people that had C. diff before, or our environmental surfaces, or us, our hands, or just overgrowth from pre-existing strains. We have a real lack of studies to really guide us in terms of what's the most effective, best way to decrease transmission from asymptomatic carriers. And it's really right now, it's very unclear if we were to ever start testing asymptomatic carriers, how would we do it? So this is an area that's ripe for discussion and research, but active surveillance is definitely needing much more exploration before we go down that route. And the next slide just in terms of the role of asymptomatic carriers, so I've already mentioned, we know that infants are going to spread this thing at least in their first year of life. By the time we're at age 3, we kind of remain stable throughout our lifetime. Around 3% of people are asymptomatic carriers. I've already mentioned that we know that asymptomatic carriers can potentially spread it. But if we think about it, if the risk of transmission is minimal, especially in somebody that does not have diarrhea, if we're truly practicing standard precautions, then we should greatly minimize the risk of or the role of asymptomatic carriers in our setting. And only about 20 to 30% of new cases of C. diff can actually be directly linked to a known case of C. diff when precautions are followed. So that's the important role of the asymptomatic carriers. So the next slide is really, if we were to test, how would we do it? Well, we'd need to have something that was extremely fast and extremely sensitive. We know that the gnats are only approximately 60 to 70% sensitive to pick up asymptomatic colonization. And then culture is really the most sensitive is the media that's culture, but it's not fast enough. So that's definitely not going to work. So the next slide is really, I think, an important question. And I've always, this is something as an infection preventionist, something I've just said a million times. Be careful what you ask for. Let's only culture something if we're going to do something with the information. What are we going to do with the information? Is it going to drive how we treat the patient? Is it going to drive how we handle the patient? So, for example, if we screen all these patients, do they all get put on enhanced contact precautions? Who has enough private rooms for that? How does that impact staffing? And how does that impact patient safety and patient satisfaction? So the next slide is really kind of the big question that I really don't think we have the answer to right now is what's the best test, the best single test? Because they all have some advantages and disadvantages. So the next slide is something that I think is really critical and we all struggle with, is that how does the test that we use impact our rate? The test that we use has a major impact and certainly has a major impact on what is publicly reported. Here's the important statistic on this slide. Up to half of patients that are hospitalized with toxigenic C. diff and diarrhea will test negative for fecal toxins by immunoassay. So because of this, we tend to revert back to saying, well, the EIA, it's just not sensitive enough. So we've been historically blaming the test and saying, well, the patient probably really has it. It's just a false negative. But the real question is, could this really just be C. diff colonization in a patient that has another explanation for diarrhea? So that is really where we need to be going in terms of our thought processes for interpreting tests that are potentially negative. The next slide is just a screenshot of NHSN because I didn't want to forget to just mention this. And then if you go into the next slide, Jill, currently anyone that's entering or submitting data to NHSN is required to indicate what tests your laboratory or the outside lab that you send your specimens to is using. And it's really important to be able to record this. I was not able to get any information on what people are sending to NHSN. So if anybody out there has access to that, I would certainly love to hear. We believe that many people are using PCR. Some people are still using just EIA as a standalone test. So what's important to remember is the test that we use greatly impacts our rates. And I believe that most of us that were using just EIA and then switched to PCR, you saw a dramatic uptick in your rates. And you probably had to go to your committees and your boards and explain, well, gosh, why did we go from this low rate of C. diff to this huge rate? And then likely you explain, well, we're using better tests now. And the reality is, yeah, we're using better tests, more tests that are more likely to pick it up. But now we have to start asking ourselves, are we using a test that's more sensitive, but we're using it incorrectly for patients that have a low probability of having the disease? So the conversation really needs to continue in this area. So I'm going to shift to the final part of this discussion. And I guess I don't really think. I know from the colleagues that I speak to who are working in hospitals are under such pressure to capture presence on admission. Because if you capture it on admission, we don't have to count it. So it's the whole, gosh, we really want to make sure that we identify this patient with C. diff before that witching hour when it suddenly becomes hospital onset. So we're under tremendous pressure to do this. What it's done, though, is it's really impacted our culture of culturing. Here's a brief just case scenario. We've got an 84-year-old, very frail patient with a lot of comorbidities. He recently fell. He had a laceration. He has a history of dementia and psychiatric disease. So you're thinking, oh, great, we're not going to get any kind of a history out of this guy. It's going to be impossible. So what do? Well, typically, we're going to do a physical assessment. So the next slide on physical exam, oh, wait, this patient's got a urinary drainage bag. Oh, what's this about? Oh, he's got a suprapubic catheter. Oh, gee, well, I guess he must have a UTI. So the bottom line is when they did the physical exam, the patient didn't have any pain, didn't have any fever, didn't have any chills. He was basically unsteady. But what is the most common reaction to a patient like this? What are we going to do immediately once we see this funky urine? We're going to treat them for a UTI, even in the absence of fever. So this is a real critical thing. The next slide is really to remind us that we've got to be more critically thinking about how we treat and how we actually interpret data, whether or not it really requires antibiotic treatment. The next slide is just a very, just a snapshot of a study that was presented during ID Week in 2015 by Mullen and colleagues. This was at the Cleveland Clinic, and what they really got to was focusing on the IDSA guidelines that really emphasize the need to critically evaluate patients, especially patients that are critically ill, for the presence of fever, and not to automatically culture urine, because when we automatically culture urine, we're doing a huge scan and are very likely picking up asymptomatic bacteria. And the problem with that is we're treating patients with antibiotics that probably don't need to be treated. And the next slide is just a snapshot of another study that was published in Infection Control Hospital Epidemiology this year. It was a really nice paper on just what our culture of culturing is and how we treat positive urine cultures. And this study was really about recognizing that we're treating a lot of patients who have asymptomatic bacteria. They've got bugs in their urine, but they're not sick from it. And we should not be treating these patients with antibiotics that ultimately put them at much higher risk for C. diff. And then there's a really nice paper, and I can make this available to you too, Jill, by Bob Garcia and colleagues, where they're studying the impact of how we do blood cultures. And again, the culture of how we culture, when we culture, why we culture, we have to be so mindful of how we're doing this, because when we get results, we're more likely to treat a patient for results versus treating a patient for an infection. So my few final thoughts on the next slide is that it's really, really paramount that we treat the patient, not the test. The most expensive test is one that does not work. So some of the pushback that we're hearing from a lot of clinicians is that, PCR is great. We're not going to go ahead and do any further testing because it's too expensive. So the question we really need to ask ourselves is, what's more expensive, another test or falsely identifying a patient, treating them for C. diff infection, and potentially causing more harm than good? I did recently become aware that there is a test on the market. I'd be interested to know if anybody's using it, that does test for CDH and Toxin EIA at the same time. So it would be ideal to be able to have a test that was quick, that was highly sensitive, that could test for both things. That's really the answer to our prayers that we desperately, desperately need. And then the real final comment is that we've got to correlate clinical conditions, clinical symptoms, if we're going to understand whether or not any new test is going to be useful in diagnosing C. diff infection or C. diff disease. So I think I've gotten to the conclusion, and I was hoping to have more time for discussion, but let me turn it back to Jill and see if there are any comments or questions in queue or any requests for further information.
Okay, so I do want to remind people that if you have a question for Barb, you would hit *7 to unmute your line, or you can pop your question into the chat box, and I will see if Deanne has anything she wants to ask Barb while I'm looking at the chat box.
Hi, Barb. When you're sharing the University of San Francisco's top-down flow sheet, is that something that's easily accessed on the web, or is that something you could provide our participants today?
I will provide you. I will send you the PDF of, I've actually got a couple of other samples. I will provide you with all the samples that I have of other people's flowcharts. I'd be happy to do that. And you can share them widely.
That would be wonderful, because I think for a lot of members, they like to show that it's not just one organization doing it. Sometimes they need to show their administration it's multiple institutions have worked on these, and they get a little more support.
Absolutely, and I think what's really important to remember is that it's so much easier to start with somebody else's something, not a blank sheet of paper. And you might take a few from this and a few from that, and say, "Oh, this makes sense for us. This doesn't." So yeah, I will go through my my folders and send you anything I have.
Thank you so much.
Of course.
I don't see any questions, at least right now, coming through the chat, Barb. So just a reminder for everybody, it would be *7 to unmute your lines to ask your question.
And I would just encourage everyone, I hope that my primary role today, or my primary objective today, was really to start the discussion and showcase some of the real important things we need to think about in terms of how we test, why we test, and why the selection of the test and the interpretation of clinical data. Again, remember what is the likelihood of the patient we're testing for the disease? What is the likelihood of that patient having that disease? That is way more important than sensitivity and specificity. So that is a real key thing I wanted to just remind everybody about.
And I'll say, Barb, at least this is Deanne. This is the most complete presentation I've seen in many years about testing. So thank you so much for sharing your expertise with us.
Oh, you're very welcome. It's really been my pleasure. And I like to learn from everybody. So anybody that has any comments, you've got it. If you go to the next slide, you've got my email address on the final slide. And I would encourage you, if you have any questions or you just want some specific information that I didn't share today, just shoot me an email, and I promise to get back to you. And if it's something that you're asking for, then my guess is other colleagues will want the same thing. So we will share widely and make sure that anything that comes my way that looks like it might be useful, I will distribute and share with the team, and it's all yours to use.
Excellent. Well, thank you, Barb. And I did want to remind the members on the phone call today that Metastar does have a Bristol stool tool. We call it that new Bristol stool tool. Remember, it's totally adaptable, and you're able to actually document for your electronic record what sections or what they're to select to use the right words that match the stool, as well as you're able to add in when you want testing done, as well as when you want isolation initiated. So just remember that is on the www.lsqin/HAI. I had to think whether it was forward or back. Sorry, people.
And this is Jill at WHA. We'll go ahead and for those of you, we'll send you the link again, too, for the slides when the recording is available. I know that there was one individual that was having issue with the sound, so hopefully she's able to listen to it on the backside. But again, the slides, I'll send you the link for that, as well as all of the information that we've kind of shared today and whatever Barb will provide us as well for those additional tools. So it'll be a little bit just to get that attendance report for us so that we can send it out, but anticipate those coming later next week. So I'll just do a last minute if anybody has an additional question. It would be *7 to unmute your line. All right, and I checked the chat as well, and I don't see anything there. So at this time, I just wanted to again thank Barb for doing a wonderful presentation for us. As Deanne said, it was really good. I mean, I think this is really what we've heard from our member hospitals in terms of things that they were interested in hearing more on the details with. So we really thank for everybody for being on today's call, and again, thanks Barb for all that you've done on this presentation.
My pleasure. Thank you very much.
All right, everybody. I hope you have a great rest of your June, and we will be in touch. Thanks, everybody.
Thank you.